Good evening, everyone. You're welcome to our virtual event, that's Gratitude Professional, GTP 2021. And the main topic, as you all know, is managing the impact that the pandemic has on everyone today. As you all know, we know that we are not in normal times. Everything is different, and there's been a lot of negativity going out there. But today, we know that there are some other advantages that all this has brought. One of such is today we can reach out to everyone globally. So yes, we are happy to bring you this event tonight. And before I even give you a brief information about who GTP is, I'd like you to do me a favor, and that is just to share your screen, share with everyone on your platform. If you're watching us live on YouTube, please share. Just look down on your screen and click the share button, and you can either copy the link or you can just share straight to the platform that you want. Or if you're watching us on Facebook as well, share with your contacts as well. You never know. You may not have a question, but someone else may, in your contacts, may have a question that will help them. And this moment may be a game changer for them. So yes, I hope you've done that. We can move on. Okay, so who are we? Who is GTP? So GTP stands for Graduate Professional. I know when many people hear graduate, they tend to log off, but that's not the case. Graduate, we are all graduating from one level to another level in life in terms of our performance and the capacity that we are in. So it applies to all of us. And we also believe that somebody is always a step, at least 1, 2, 3, or 4 steps ahead of us, or where we would like to be. And this is where GTP comes in. We bridge that gap by providing mentorship programs or bespoke events such as what we have today, so that we can connect with the right people. We can mentor or give the platform for others to be mentored into their full potential. And the founder, called Dr. Douglas Ejapong, who I'm privileged to be married to, has a big heart. And his heart really is for the youth. One thing he believes in is raising leaders today and tomorrow. And this is the reason why we are here today. Every aspect of whatever that we learn helps us to move on, whether in terms of what is happening today with the impact that the pandemic has. It has affected us economically, physically, our well-being, totally. And that is why we have this program today. But I'm not going to take too much of your time today. Someone may ask, who are our audience? Our audience are professionals, entrepreneurs, graduates, undergraduates, anybody who is willing to move to the next step up. So I hope you are ready. I cannot wait for what the panelists have for us today, because I know they are fully loaded. So get your pens ready. If you need a drink, get a drink. If you need to contact us, our details will be provided on all our platforms, and we can start the dialogue. So you are welcome once again to GTP 2021, Managing the Impact of the Pandemic. Thank you.
Good evening, everyone, and thank you for joining us tonight. I think we couldn't really go on until we introduce ourselves. My name is Dr. Kuru. I'm a GP. I work in the UK, in London, in an area of South London called Lambeth. I see patients every week, see patients who've had COVID, patients who are suffering from COVID, and we also come home and we speak to family members and friends who are suffering indirectly or directly from COVID as well. I think the main thing is that COVID has impacted everyone internationally, and we can see that by having an international audience today. I hope you'll be informed. I hope you'll feel free to share questions. We will share the nuggets of information that we've garnered over this past year. And I just hope it will bless someone, it will encourage someone, and you'll be informed. That's what we want you to do. We want you to make an informed decision about the COVID vaccine. We want you to make healthy decisions regarding COVID, and we just want people to keep safe, and hopefully we can save some lives today. So before we continue, I wondered if each of the panel members, if they could introduce themselves at all. I don't know if the back office can help me out with that. And we can start with any of the doctors, maybe with Dr. Daniel Osigbe, if you don't mind introducing yourself. I think you're muted, Daniel.
Thank you for that. Good evening. I'm Dr. Daniel Osigbe. I'm also a GP in South East London in an area called Wandsworth. And I'm glad to be here with you, and hopefully we can make some progress together with regards to our questions with COVID.
Brilliant. We've got a couple surgeons in the house. If Dr. Yao Obeng Nisai, if you wouldn't mind introducing himself.
So, yes, I'm Dr. Yao Obeng Nisai. So I am head of surgery for Mission Hospital, St. Martin's Memorial in Accra. And so for us, for surgeons, now every patient who has to come for surgery basically has to have a COVID test. And so if you're positive, you don't get to come through. But for the emergencies, maybe you may have to operate on them. And so basically that's it. Yeah.
Brilliant. And next up, we might as well have another surgeon. We can have Dr. John Afolayan. I think he's there. If he's not there, we can go on to Dr. Chichi Ekator.
Hello, good evening, everyone. Hope you can hear me. My name is Dr. Chichi Ekator. I'm a colleague of Dr. Daniel, Dr. Kuru, and Dr. John. So I'm a GP in London. I also am part of 52 Medics, which is an organization or an initiative of an organization called Ascension Trust that really seeks to reach out to people, especially at this time of COVID-19, and just help wherever we can and spread the message for people to protect themselves and stay well.
Brilliant. And last but definitely not least, we're going to another continent altogether, to Dr. Kwatang, I believe in the USA.
Yeah, thanks, Dr. Kuru. I'm Dr. Collins Kwatang, private interventional cardiologist out in Southeast Georgia, USA. I'm a veteran of the United States Army, combat combat corps, board certified in internal medicine, adult echocardiography, nuclear cardiology, general cardiology, and interventional cardiology. So my area of expertise is acute coronary syndrome and structural as well as peripheral vascular disease management. So I cover all. If I can get a wire there, I can fix it. Yeah, so that's what I do. In my role, I'm a private physician, so I have credentials at a local community hospital. I came to this area because as a cardiologist, as an interventional cardiologist for that matter, you want to go where the disease is and to make an impact. So if you look at the map of the United States, and you look at the southeastern half of the United States, if you look at any epidemiologic maps, you can see that that area is darkened. And the reason that area is darkened is called a stroke belt. You have a higher population of cardiovascular diseases in this area. So I decided I wanted to come to where the action is, and that is why I came here to set up my private practice. Now, how am I involved with COVID? As a cardiologist, most patients who are coming in have some sort of cardiovascular issue that needs to be addressed. So as a private cardiologist, you get consulted many times to go see. And I'm also a recovering patient. I have been hit by COVID, and so because a few of our colleagues. So I'm above ground, and I guess I'm grateful. I'm very, very happy to be here.
Oh, brilliant. Thank you. And our other colleague who will be here a bit later is Dr. John Afolayan, who's a surgeon, an amazing and skilled orthopedic surgeon, also resident in the UK. Oh, are you here? You can introduce yourself.
Thank you so much for that. I don't mind you introducing me, but I'm sure you do a better job than myself. Once again, it's a pleasure to be on this forum with all of you, and thank you for the invitation. My name is John Afolayan. I'm a UK-based trauma and orthopedic surgeon. Specifically, my interest is in spinal surgery. It's complex spinal surgery that involves injuries and deformity correction. So that's what I do in London. In terms of my particular interest in this forum and with our community, as well as with COVID, with a lot of individuals, including Dr. Kuru, Daniel, Dr. Chichi, we really have felt the impact of COVID-19 in our communities in terms of Black and ethnic minority folk. And, just feeling the need to be part of the process of change. I fully appreciate that what we're witnessing is not just a COVID-related issue, but there's a lot that we can do to help our communities. So on a day-to-day basis, the nature of my work completely changed to deal with the epidemic, and it's only now that we're slowly returning back to normal. So thank you for having me on this forum, and looking forward to adding my little bit of knowledge.
Brilliant. Thank you so much. So I thought we also have to thank the back office. We've got Dre in the back office who's helping us keep everything in check. And before we continued, I thought I hope it will be okay if we just share a video with you. It's just over 6 minutes. I think it sums up a lot of the COVID journey, both for medics and for us as family and friends. And we'll pick up from there with some questions and answers afterwards, if that's okay. So Dre, when you're ready. Thank you.
The last time I saw Paolo was the night he was moved out of ICU to my hospital ward. Paolo, you look better. I've known him since I came to the UK 25 years ago. He's like a father to me. By God's grace, he says, wheezing through his oxygen mask, I will be alive to tell the pastor to hear you. Sure, Pa. Good night. Paolo. He's one of the wisest people I know. Imagine my shock 2 months earlier when he came to my outdoor get-together and agreed with my wife, Fola, and our 2 other guests that the effects of COVID-19 are exaggerated. They believed these WhatsApp messages that were being shared across their networks. I warned Fola, don't share them. Fola says, but they are true. We Africans are immune to COVID. Fola, I could understand. She was living in northern Nigeria when the meningitis trial scandal broke. But Paolo. So I say, many of my patients are our people. Oh, so we Africans are the ones spreading the virus, Pa replied sarcastically. No one is saying that, Pa. Many of us do jobs that expose us to the virus. We live in deprived areas, pre-existing conditions like your diabetes. They all make us susceptible to it. Fola says, you're a nurse. You haven't contracted it. Fola, you know the PPE I wear protects me, I hiss. Pa says, God, who is seeing me through my diabetes, will see us through COVID-19. Amen, yelled everyone, putting an end to the debate. You don't understand, I press on. Yes, we are stupid. You are the expert, Sammy huffed. He was one of our junior pastors. I didn't say that, Pastor Sammy, I replied. Pastor Adas, our other guest, also a junior pastor, chimed in. You sound like that doctor that came to the community center to talk about the trials. He dismissed my concerns as if I were a child. Fola squeezes my hand, her way of saying, stop arguing. After our guests leave, Fola says, I told you not to bring this up. I tell her, since the trials began, not one Black person has volunteered. Maybe if I join, that will convince our people. No, she says emphatically. The trials are conducted under the strictest conditions, I assure her. And the side effects, she asks. I won't know until I take the vaccine. So it's like they are giving you food without telling you the ingredients they used, she says. If we don't take part, the vaccine will be tested only on white people. It will be tailored only to them. That's okay, she says. We are immune to COVID. The following night at the hospital, Paolu tells me he will record a message for the congregation on his phone. He wants them to see how badly COVID is affecting him. He is too tired now. He'll do it in the morning. The next night, I returned to find that Pa had passed away. I call our senior pastor, Michael. He says the church will arrange the funeral. He will contact Paolu's brother in London. I was not on duty when the brother came and took Pa's belongings, including the phone. To be honest, the phone was the last thing on my mind. At a Zoom meeting before Sunday service, I asked if I could address the congregation about the trials. Pastor Sammy says, we've been through this. Pastor Ada says, Pa's death has made me rethink my concerns. We should let Brother Jide talk. The congregation believes God is in control, Sammy replies. When you are hungry, you do not open your mouth and say, God, feed me. You find your way to the kitchen. Pastor Michael says, first, the authorities said it would be years before a vaccine is found. Now they say they have all these vaccines ready to inject us with. I feel like I'm losing them. Then I remember what Fola said to me after Pa's death. Pastor Ada was right. You should know how to talk to your own people about the virus. They are afraid. I'm afraid. So I say, forgive me if I sounded like I dismissed your concerns about the vaccine. But we can't be left behind on this one. Science has advanced. The time for testing and approving new vaccines has been cut greatly. Paolu wanted you to know that COVID-19 is real. How I wish he were here to tell you himself. There is a pause. Then Pastor Michael says, I think we should let Brother Jide talk to the congregation. Pastor Ada nods. Pastor Sammy says, I remain skeptical, but the congregation should hear Brother Jide speak. Before I'm called upon to speak, my phone rings. Paolu's brother has emailed me Pa's video recording. As I listen to Pa struggling for breath with each word, Fola wipes the tears from my face. Pastor Michael calls on me. Instead of speaking, I raise my phone to my laptop's webcam. Brothers and sisters, I'm living proof that COVID-19 is real. Please assist Brother Jide to help our community to fight this problem. God bless you all.
Thank you, Dre. Thank you. So I hope that video kind of conveyed maybe what we want to try and convey today, and that really is how can we help our community? And it's not about pressurizing people to have the vaccine, but to really understand the implications of this terrible disease. A lot of people are saying the last time I saw my mum, my dad, my auntie, my sibling, and many people have died. And the only thing we have got is the last time we saw them. And we don't want that to be the story for many people's lives. I wondered if Dr. Kwarteng, I know you touched on it a little bit, if you could tell us a little bit about your own COVID experience. You said you've been through COVID yourself, maybe educate people a little bit on their symptoms and maybe even when to ask for help and what to expect with COVID afterwards.
Yeah, thanks for the opportunity, Dr. Kuru. Yes, I have. So, as I intimated earlier, I work out in Southeast Georgia. My family is in Atlanta, about 150 miles away. They used to be with me. We moved from Las Vegas here. And, you know, I live in typical Trump country. So not that very progressive thinking. And that is just being very truthful. And the school system is bad. I have younger ones. My younger daughter is about 10. Next after that is 15. The 17-year-old I just entered first year in college. And the eldest is a third-year medical student at Morehouse Medical School. So the younger ones came with me, and then I realized after 1.5, 2 years that their progress, you know, with respect to education was really lagging behind what we used to have. So upon consultation with my wife, I decided that I'll find a place in the best school district. So I moved them out to Gwinnett County, in the city of Atlanta, where the school district is really good. It's run the best. So because of that, with the investment I had made in the community, I just couldn't pick up a practice. Plus, in the city of Atlanta, all the big hospitals have bought up all the private practices. And based on 2 previous experiences, I swore that I would never be employed again. Okay, if I go out and I make $1, I know it's my dollar. So I moved the family out to Atlanta. So the way it works is that I stay here through the week, Monday to Friday. And if I'm not on, you know, acute MI call for the weekend, I'll go home. And if I'm on call, they will come here. So I had been away for 2 weeks. And that Friday, January 15th, was the day I was due to go home. The very morning, my lead clinical nurse called me in the morning and said, I'm not coming in. I'm like, what do you mean you're not coming in? We have a schedule full, you know, spilling over. So when you are there, the place runs better. She's like, I'm not coming in. I don't feel well. And as soon as she said that, I said, what are your symptoms? She says, you know, I have a scratchy throat. I have a headache. I said, you better go to the medical center and get checked. So I headed out to work, and she texted me an hour later that her rapid test was negative. So I came in. That weekend, we were bringing in a special cleaning crew to come and clean and sanitize the office. And we have been extremely diligent. I mean, we cleaned that place like there's no tomorrow. I've spent a considerable amount of money on cleaning products and making sure that we go through the protocols. A day before, we had a patient come in who had been referred from a general practitioner, complaining of chest pain. And the nature of the symptoms were worrisome enough that we decided to do a treadmill stress test. So she came in, we screened her at the door. She comes in, and I put her on a treadmill. But as she's doing the treadmill, her mask kept, you know, falling off. And the EKG on the EKG machine had a very wavy baseline, difficult to interpret. Now, she's a middle-aged woman. I'm a male, so I didn't want to be isolated, the two of us, with me touching her chest and all of that to try and straighten out the EKG leads. So I called 2 of my female nurses to come in and help me conduct the test so that they could help stabilize the EKGs on her chest. They came in, they did that, the EKG got better. But so as I go back to think about it, I think it was that patient, because myself, my 2 nurses, and the front desk who checked her in, all of us tested positive. Okay, and the only person was a young lady, one of the clinical nurses, who did not get in contact with the patient at all. And so as on Friday, as I was getting ready to leave, I felt I was having some difficulty breathing. And then as I was lifting charts, and we've lost a lot of patients. So I have all the deceased charts, like patients who have passed away, and it's piling up very quickly. And I couldn't leave them on the carpet. So I decided to lift them to higher ground so that the cleaning crew could really shampoo the carpet and everything. It was just maybe 10 charts. And as I did just that minimum amount of work, I started getting short of breath. And then all of a sudden, I started getting, like, you know, wells of sweat on my forehead. And I was huffing and puffing. So my staff is like, are you okay? I'm like, I don't feel okay. But I had just seen a few patients. So I went straight to the local medical center, and lo and behold, my test came back positive. And for the subsequent week was the worst the worst week of my life. COVID really brought me to my knees. My symptoms, excuse me, started with just severe diffuse body aches. Even blinking my eye was a problem. I had severe GI symptoms, difficulty breathing. My Tmax was 103.9, and that was the evening of the diagnosis. The good news, I guess, or the silver lining out of all of this was that when this pandemic started back last March, I belong to the Ghana Physicians and Surgeons Foundation of North America. I'm just a member, I'm not in leadership. So when the numbers started picking up back home, we had a meeting to try and see how best we could help back home. And so my big mouth got me in trouble when I suggested that we should write a white paper. So the president said, well, since you brought it up, why don't you lead the crew to write a white paper? So we had the opportunity to do a lot of literature dive, and that is how an interventional cardiologist got involved with something that apparently is an infectious disease issue, but then something that was. So I had the opportunity to review a lot of literature articles, what works, what doesn't work on the initial stage. So with that in mind, I felt I had the a priori knowledge to compare to my colleagues to be able to get on top of it. But man, I couldn't go home, obviously. I couldn't go home and infect my whole family. So I self-isolated for the first 10 days, and my goodness, it took everything out of me. You could not, when you get up in the morning, you cannot, I mean, my master bedroom, the restroom is right there, literally 10 feet away, and I didn't have the strength. You know, I'm 6'2", 240 pounds of, solid African man, and I could not get up to ambulate just 10 feet away because of the nature of the disease. So that has been my experience, and I think most people ended up seeing the video I made. I decided to chronicle, and that goes back to my interaction I had with a patient when it started, and when I tried to encourage him to share his experience, he was 100% opposed to that. And so from a provider's point of view, and with the pandemic ravaging through our community, I felt like if somebody knew what I was going through and how I was managing it, then perhaps it was going to be beneficial. And if it ends up saving just one life, then it is worth, that exercise. I had no clue that the video I made was going to take a life of its own. And the next thing I knew, 5,000, 10,000, 20,000, 30,000, 50,000 and climbing. And because of that is actually the reason why I ended up here, I guess. It is, the way I call it, an evil disease. Okay, you do not wish it on your worst enemy. And to buttress the point, when I first came to this area, I was recruited very highly from Las Vegas, Nevada. I was brought here. A facility gave me 5-year income guaranteed contracts. But then I was paired with an elderly gentleman who was had been in the community for about 15 years at that time. And being younger, coming from better training facility, a 5-year income guaranteed contract, I lasted only 5 weeks. And the reason I tell you that was because the management sort of looked the other way as my rights were violated. And when the pandemic started, this gentleman, decided that, all of this is a fluke. And the reason I'm bringing this up is you don't wish it on your worst enemy, but we're losing that gentleman due to coronavirus. Okay, so we lost a pillar, and he and I did not get along. Everybody knew that. However, it hurts me to the core that, you know, we lost somebody like that in the community. So I say that to drive home the point that this disease is no respecter of persons. It does not matter what your status is, what sort of degrees you wear on your shoulder or on your white coat. It will take you out in a heartbeat. So that is how my diagnosis got made, and that is how I continue to sort of try any and everything I could do to survive the disease.
Thank you for sharing that. I know in the UK it is relatively easy for us to get tested if you have symptoms of change or loss of smell or taste, or if you have a new persistent cough, or you're feeling hot, or you have a temperature. We can call 119 in the UK and get a test. But funnily enough, a lot of people will sit at home with any variety of those symptoms and actually not get tested, but tell you that they do not have COVID. This is about not only keeping yourself safe, but actually not passing it on and isolating appropriately. And just having that in mind, that we have access to that in the UK. I just wondered, Dr. Obeng, if you could tell us how it is in Ghana. Like, what do people do if they have symptoms? What should they do? How do they manage with the facilities there? And feel free, panel, if you want to contribute at any time.
So okay, I'm also just recovering from COVID, and I like his closing remarks. Like, it's the thing you never wish for your worst enemy. And I don't know anyone who's had a moderate to severe COVID who ever missed that line. You don't wish it for your worst enemy. It's the most terrible time. It's been the most terrible time of my life. I mean, I want to go back a little. He had these GI symptoms back here in Ghana, or in Africa. We are mostly used to malaria. So on the 22nd of January, I woke up around like 4 a.m. with chills, with fever, just like malaria. So I just got out and with a sweat, cold sweat. And so I got up and went to the medicine box, grabbed some medication, this is malaria. And for me, I don't have to take more than 2, tablets of anti-malaria. I do get better. So I don't have to complete a full course. But then after the second day, I begin to feel like, this is different. There's this muscle pain, there's this weakness, there's this fever. And, I was spared the headaches, the loss of smell, but my appetite was 0. The only thing I could do was a kind of tea that the aroma was a little good, and I could just take a jug. I couldn't eat, So the test came in after 48 hours as a PCR test, and then I had to isolate at home. And then I called my colleagues from the center, the treatment centers. They came to see me because they could gauge. At that time, I had become breathless. I had become weak, and it was hell. So this was the initial stage, and it got worse with a cough, with the weakness. I mean, I couldn't sit for maybe 3 minutes without putting my head down because I was that weak, and I can't complete a sentence. If you say one word, that's it. And I couldn't. You can't pick calls. You're not interested in anything than, getting your strength in your life back. And I think it got worse. It got worse. I mean, some of my colleagues got scared because they couldn't reach me on the phone. They kept calling, but obviously I couldn't answer. I wasn't interested in also texting. And it's only the people who were monitoring, checking up on me, who I could communicate with, because I had to give them feedback. And I mean, around the 9th, 10th day, I realized, your appetite. That was the first thing. That was the first time I realized my appetite was. I mean, I woke up around past midnight, and my appetite was a little better. So I was hungry. But way before those times, you're weak. You have all this muscle ache. You have all this, difficulty in breathing. You can't talk. You can't complete a sentence, and you are wondering, when will this be over? Is it going to get, worse, or it's going to get better until finally you get through. One of the life-saving things, maybe he didn't talk about it, was paracetamol, acetaminophen. It was such a lifesaver, and also the corticosteroids they give, the Dexa. It was a lifesaver. Those things saved my life, such that I didn't have to be taken to the hospital. Even though there were nights I thought that I wouldn't make it, and I never slept till morning when everybody was awake. That's when I'll sleep, because I didn't think the way I was having difficulty in breathing. I mean, I wouldn't want to sleep. I would want to be up. So this was this is maybe just a summary of my experience, and I bet you won't wish it for your worst enemies. Let's come to Ghana. Ghana, we started well. We had the test, trace, isolate and treat, and then we had stringent measures at the airport. But over time, all of that, we've lost it. The airport is open, and then here we don't have that free testing. For a health person, you can go to the facilities like Noguchi, you may get it for free, but most of them you have to pay, and it's a little bit expensive for most people. And so it's now that they brought, the government brought a paper that maybe they should allow people to test for free, but I don't know how workable that is, and I don't know any information about how it's going. But largely, most people pay for it. And because it's so similar to malaria, people get sick, they are seen by GPs for a number of days before later they get to do the COVID test. But now it's changing. Maybe the COVID test is among the first battery of tests they may order. So the part for us in Africa is obviously going to be resources, right? Because the government may not have the money to allow a lot of people to test. And because we may not have that large-scale testing, it's always going to be a challenge getting to know how prevalent the disease is. It's only those who are affording, who can afford, and it's only those who are possibly traveling who need to get a test before they can travel. There are only those ones there are only those statistics that you get. So that's what's with the testing here. That's how the testing regime goes. In the clinic, in the hospital, aside for us to operate on someone for an elective case, the person, aside everything, has to get a COVID test before. But for emergencies, when they come, we also examine them, and they also do get a COVID test. I haven't had to operate on someone with COVID yet, but I got it from a COVID patient who I had to see because he had surgical complaint. I would that's what I would say. Yeah.
Brilliant.
For now.
Thank you. So we can see that it's definitely affecting people in Africa. I know initially, and even now, people do say that African people, Black people, are immune to COVID, but we can see that they are definitely not immune. The challenge in Africa comes from, how do them people afford care? How do they afford care? If you're unwell and we're educating on you and how to seek help, how do you afford care? I don't know how to answer that question. Anyone can contribute. But I thought one of the things that really hit me from the video that we saw before is that they say, by God's grace, by God's grace, we'll get through COVID. By God's grace, I won't get it. By God's grace, it doesn't exist. I wondered, Pastor John, in your capacity as pastor and surgeon, I don't know what you think about that, and is it something that we overcome, or is it something that we embrace? What do we do?
Overcome, we must. Overcome, we will. So maybe I should put on different hats at different times. So from a faith point of view, I think we'll definitely overcome. And as a human race, we will overcome because time and time again, the human race has many challenges in its history, and we are survivors. But it's the nature of that overcoming that is important. And what I mean by that is that what is the cost going to be for communities like ours, and what are we willing to lose? Um, there's a balance to be struck between faith and science. These aren't issues that have to be at loggerheads with each other. With my scientific hat, and having witnessed the direct and indirect effects of COVID, treating patients in the National Healthcare Service, with the science that Dr. Collins has explained, you know, we know what it is as best as we can for now, and we have something that could potentially work. The challenges when it comes to which part of the world you're in are very real, and certainly the challenges in Africa are very real. Dr. Obeng and Sia, I'm very interested in what you were talking about Ghana, because I work with a number of, my hospital is based in North London, and we have a big population of Ghanaians in the healthcare system support, because that's just somewhere where we find a lot of Ghanaians. And one of our anaesthetists and critical care doctors was telling me about maybe some of the initial work that Dr. Collins was talking about. And really, I was very impressed by the Ghanaian response in comparison to other West African countries, which I won't name. And actually Ghana's model and the way they tackled it really was one of the leading models in the world. But all that being said and done, we have a disease that's highly contagious, that is deadly. And in the communities in and around London, it's caused absolute carnage and ravage. And we're talking about generations of people that have been lost. So I think it's important for us as people in the healthcare sector, people of faith, to make sure that the right information is being communicated, to make sure that we help our communities as best as we can.
Brilliant. Thank you. So I thought maybe with that in mind, if we could maybe go back to kind of like the beginning of kind of where all the controversy with the COVID vaccine started. And one of the most common questions that are asked is how is this vaccine made so rapidly, and why? And with the other additional strap lines of there's no cure for cancer, there's no cure for HIV, how is it that they've made this in how many months? And I wondered if Dr. Daniel could help us to kind of, unpick that and answer that question for us.
I'll try my best, hopefully. I'll probably touch on, if we talk about cures for HIV and cancer, I think just as a pretext that we are actually making rapid developments, and many cancers over the years have actually become curable. Obviously, some cancers are treatable and maybe not necessarily curable, but we are always making progress. And even with HIV, treatment has improved. If you remember back in the 70s and 80s when people were dying all over and we had no form of treatment for it, and now actually basically HIV patients have almost a normal life expectancy, and in some cases a normal life expectancy depending where you live. And even now the treatment is fantastic. We've got the single so we've got new treatments that are coming out that you probably would hear about shortly. Sorry, I just got babies in the background. And coming back to how the vaccines were made so quickly. So I think the COVID virus is not. It's a new type of coronavirus, but however, we are very well aware of coronaviruses. These are the viruses that causes the common cold. These are one of the viruses, and we've been working on vaccines for coronaviruses for a long time, so about 30 years now. And so it built on initial research on that. So it wasn't that hard. This is just a new virus in that family. And because it was a pandemic and it was affecting basically everybody in the world, it was something we all had to tackle. And essentially, lots of people, companies, countries basically came together, provided the money, the finance, and the human resources. And that's why it was done so quickly. And also in terms of the research, a lot of the research during phase 1, 2, and 3 of the clinical trials didn't necessarily wait for each phase to be completed before starting the next phase, and they kind of layer the phases on top of each other. This was a risk that the researchers took, but they were monitoring the results all throughout, because if one phase failed, they would have lost more money, lost the time, and have had to start again. But it paid off, thankfully, and that's why we've got the COVID vaccines. So basically, I think my point is that technology is improving over the many decades and years, and we're at a point that actually now we can see we've successfully done it. We can make vaccines within a year.
Thank you. So we're benefiting from the progress of science. I guess science and technology has progressed in many other areas of our lives. We have mobile phones, we have YouTube, but sometimes when it pertains to medicine, we get a bit fearful about it. I was wondering, Chichi, if you could help us to just kind of maybe talk through, not necessarily the list of ingredients, but talk about the ingredients, because many people say that it's got a chip in it, it's got pork in it, it's got so many things in it. If I considered all the things that people said in it, I don't even know how they would be able to inject it into us. But actually, these are genuine fears. I wondered if you could speak about that at all.
Thank you, Dr. Kuru. I think just to add to what Dr. Daniel was saying is that in terms of the COVID-19, why we've advanced so quickly in terms of developing the vaccine is that it's quite similar in terms of its structure and the way it looks to the virus that caused the SARS disease that broke out in the East, so in the East of Asia several years ago. So I'm sure many of you will remember that in the news, on the media. So scientists have actually been working on this technology. Often some of you may have had the mRNA technology, which is the hotly debated technology that people are very worried about. But scientists have actually been working on this technology for over 2 decades. So, just to add to what Dr. Daniel said, this is not a new technology. In terms of the specific ingredients of the vaccine, so there are several vaccines out at the moment, and I think that the main 2 groups would be the mRNA technology. So you've got the Pfizer vaccine, you've got the Moderna vaccine, and then you've got the Oxford AstraZeneca vaccine, which is what we call a viral vector vaccine. So I'll talk a little bit about the mRNA technology in a sort of layman's term. I'm borrowing a lot of my terminology from a video by Tyler Perry with 2 American doctors. So if you haven't watched that, please do watch it. So people worry about, is this vaccine going to affect our DNA? Does it contain pork? Does it contain fetal cells? Absolutely not. Yes. So it's important for us to recognize the difference when they talk about DNA and mRNA to understand what that means. So in a simple sense, what they've done with this COVID-19 vaccine is based on this mRNA technology. And if you think about mRNA as a messenger, so like as a contractor, yeah? So if you're building a house, you've got your blueprint, so DNA blueprint, but you've got contractors that, will tell the workmen what to do. So if you think about the mRNA as a contractor, so once it gets into our cells, what it's done is something really, really clever. Tells our cells to produce this bit of the COVID-19 structure called the spike protein. Now, that spike protein, that's the bit that scientists have discovered. That's the bit that causes the major problems that, all these doctors have described, the worst infection in their life. So the mRNA, tells our cells, produce this spike protein. So our cells go ahead and start producing it. And then our bodies are like, hang on, there's an invader here. You know, we need to mop out this invader. And so what our body does is then produce all of these weapons, I like to call it, or antibodies. So our B cells and our T cells, you know, are called into action. And then they put this COVID-19 on a watch list. The mRNA disappears. It doesn't change your cells. It doesn't do anything. It denatures. You know, that's the scientific term for it. It just disappears. But what our body has been primed to do is not only produce the weapons to tackle COVID-19. So if it was to come and attack us, or if we were to come in contact with a patient or somebody else who's infected, not only does our bodies or our cells have it on a watch list, but it also has the weapons. So I just really wanted to clear that up, because people are really stuck on, does it contain pork? Does it contain this? No, it doesn't. So this is the Pfizer one. This is the Moderna one. And then also we've got the viral vector vaccines, which are based more on a traditional model of how we make vaccines. I won't go too much into that, but in terms of the ingredients, most of the ingredients absolutely harmless. It's absolutely fine. You're not going to turn into a green-eyed monster. We're all standing. I've had my vaccine. I feel fabulous. Can't wait for my second dose. I hope that answers your question, Dr. Kuru.
I think actually that was a good point that you shared, that I've had my vaccine. I think most of us have had our vaccine here. I've had my second as well. One of the most common symptoms is that you can get a sore arm afterwards. Some people do feel a bit feverish and get flu-like symptoms. You may feel unwell for a few days. Take some paracetamol. If your symptoms are persisting, please do let someone know. But to the best of my knowledge, that is kind of the extent of it in terms of the side effects. They are short-lived and not long-term. But then I say that, and people don't always believe me. And I think that brings us on to trust. I think a friend of mine said in one of our WhatsApp groups that, why do our parents push us into medicine? And why are our peers so proud of us about being doctors? But when it comes to listening to us, they don't. And I just wondered, Dr. Kwarteng and Dr. Obeng, I don't know, I know there's a lot of mistrust in the UK. How is that for you? Or do you have that experience of having mistrust amongst your peers in your community?
Yeah, I would like to take that. Now, let me add to what Chichi said before I sort of jump on that. And this is just by way of information based on the research we did. Now, to support the point that Chichi made, you see, the advent of social media. See, it used to be that if you wanted to send a message from Ghana to London, you had to send it by telex, right? It took you a week or so. So the flow of information was very slow. And so if you had information about even some danger, it took a while. Now with social media, everything is available to you at a click of a button. So the flow of information has been, do you remember when this thing started, everybody said it was 5G. The world is bringing 5G networks and the virus is in the 5G, and there are these quack, physicians who came on and made videos about how this is, okay. So the virus or viruses has been with us since time immemorial. The SARS and the MERS epidemic, in the early 2010s, okay, started in the Far East, and then the MERS, the Middle Eastern respiratory virus or syndrome, was in the Middle East, Saudi Arabia, and that got transmitted from camels to men. It was quite limited, and the reason why it was limited is just basically where the receptors are. People should understand that viruses are not individual sort of living organisms. It's not like a bacteria which can survive on its own, has ATP, it can divide by binary fission, and in the right environment can just multiply. Viruses do not replicate, or they do not transmit if they do not have a host. They have to jump on a replication mechanism, which is usually in a person's cell. Okay, now the reason why this is different is basically where the receptors are located. the SARS epidemic, which is a version of a coronavirus, was because most of the receptors where the virus could bind were mostly in the upper respiratory and not a whole lot in your lower respiratory. So the symptoms you got was basically in your upper respiratory, you have some sinus drainage, stuff like that, very little lower, because every patient is different, okay? You can't have even two twins, identical twins will have, different sort of receptor location. And so it was not that rampant. And so we were able to control it. And one thing that people also have to know is the reproduction number. In any sort of epidemiologic study in viruses, how likely is a virus going to spread? So if your R0, subscript 0, is less than 1, then it means that if you get infected, the likelihood that you will send it to somebody else is less than 1. Since we don't have half a human being, it means that the virus will sort of, go out of the community very quickly. If your R0 is equal to 1, for every one person who gets infected, you send it to one person. So it becomes endemic. It sort of stays, okay, in the community. If your R0 is higher, which this particular virus was, R0 at some point was in some communities 5. That means that for every one person who gets the virus, you can, before it sort of runs its course with you, you send it to 5 people. So look at what happens. You don't listen to your healthcare, specialist, and one person sends it to 5 people, 5 becomes 25, 25 becomes 125, and then you look at the exponential spread. That is why this has become a pandemic. This is why it is important for people to understand how this virus works. Okay, it works because the reason why we are having the lower respiratory and the COVID pneumonia is that the ACE2 receptors through which the virus enters your cells are mostly in the lower respiratory tract. Some of these receptors are also in the GI tract. So as you get a postnasal drainage from this, fully loaded with viruses, and you start to swallow your saliva, okay, that high-laden viral load goes through your GI system. The viruses bind to the receptors in your GI tract. So the diarrheal symptoms that we are seeing, okay, that is how it is happening. But then the COVID pneumonia is basically because the receptors are more in the lower respiratory system. Now, in the lower respiratory system, that is where you have your alveoli, right? That is where you have these cells. So in the little bronchioles, which is the lining, the little tubes leading to the alveoli where the gas exchange takes place, that is where you have majority of your receptors. So when the virus gets in there, and what it does is that it produces this very thick mucus. And my own experience, and the reason why the video I shared became so popular was because I guess what I've been told is that it broke it down to people and why the inhalation therapy was working. And the reason, I mean, I had seen this vapor therapy all on social media. But then I got to thinking about it sort of physiologically or pathophysiologically. I'm like, what is happening? There was one article, or I guess a video I saw, an interview somewhere in South Africa. I think it was a Sudanese physician, somebody who went through, like literally walked across East Africa, made his way to somewhere in South Africa, put himself through school to become, and then this interview. And what I learned from that was that when he did what we call therapeutic bronchoscopy, he will go down and he will see this very thick glue-like layering of the mucus into these little tiny holes, which leads to the alveoli. So in essence, your alveoli is jailed and it is sequestered away from gas exchange. And that is why the oxygenation has become so tough, especially in patients who are on vents and are unable to clear their throat. Now, for those of you in ICUs, you know that when you intubate a patient, the ET tube is pointing into, is probably about an inch above the carina, okay? And depending on where the patient is lying, that ET tube is sitting there, and if you try to suction, that suction only goes to where the ET tube is pointing. So you really don't have access to the entire pulmonary parenchyma to be able to suction this. And what he saw was that you saw this rusty colored, mucus plugging up all of the dependent areas, and sort of it takes that away from gas exchange. So what happens? Your PO2 drops, it shows up on the monitor. As physicians, what do? We respond to what we are seeing. So we increase your FiO2, we increase your PEEP, and as we increase the PEEP, we are causing barotrauma.
Dr. Kwarteng, I just remind you, please use some layman terms.
Oh, okay.
Even me, you've gone above my level.
Okay.
I was enjoying it actually. I mean, this is good knowledge, but yeah.
Adding to my CPD, it's adding to my continuous professional development.
Right?
Keep on, Dr. Kwarteng.
Okay, so what it is doing, so in layman's terms, the virus produces a very thick mucus. Look at it like glue. Okay, and in my experience, I could not excrete or remove this from my nasal passages fast enough. I mean, if you are, I guess, a conspiratorial, a conspiracy theorist, you would think that there are some little devils over there just shoving the mucus in your, as you, it's just coming out. And so just imagine if you were laying supine, or if you were laying on a bed in an ICU facing the ceiling, and you don't have control of your own breathing, a machine is breathing for you, okay? And you are producing this mucus, and you don't have the ability, because most people who are on the breathing machine have medication that is making them fall asleep so that they can relax and not get tired. So the machine is breathing for you. So if you have all of this mucus being created, and it layers out on the little holes, which leads to the little pouches, which does the gas exchange, it takes all of that away from what the lungs are made to do. And so the reason why the vapor therapy is good is because we know the lungs are good for gas exchange. Okay, and this mucus dries out so quickly, just as it's made, it starts to dry out. And the reason why I know it is personally, before I started the vapor therapy, I could feel the mucus in my chest, but I couldn't bring it out because it was drying out so quickly. So I figured, well, how do I get the moisture over there to loosen up so that it will be easier? And that is why the vapor therapy became very, very good, because as you do that, well, of course, you cannot put water down your nose, right? You're going to choke. So if you really want to get the water down there, you have to send it in a gas form, in the form of water vapor. So you do the inhalation therapy. It gets down to your airways, the lower airways. It condenses because the temperature is different, and it adds the moisture there. And an hour, maybe 30 minutes after that, you can start feeling, the mucus breaking up. So the people who do not do well, especially when they go on a vent, is the inability to expectorate. So now, as standard practice here in the United States, we give mucomist and acetylcysteine, which is a mucolytic. How effective that is, I think the jury is all out. But that is the reason why this disease is progressing to the extent that people who go on a vent, the mortality is about 70%. In other words, 7 out of 10 people who gets put on a vent don't make it back. Okay, so that is a pathophysiological aspect of it. And I know I'm taking a little bit too long, but let me respond to the trust issue. So in the United States, again, the governmental policy back in the day when syphilis, first broke out, the US government directed a policy where trying to test for syphilis, except in the Black communities in the southern United States. They lied to them and told them that they were treating them, where in fact they were just giving them a water pill and then allowing the syphilis to just burn through the Black population. So and we know what syphilis does. It created havoc okay, in the Black community. So when the word got out and people realized that, wow, our government really, who is supposed to protect us, actually did this to us, it created that mistrust until today. And then you have people like the Bill Gates and the people who have, the Rockefellers, who have come out, okay, and supporting policies of eugenics. In other words, breeding for, like, quote unquote, the best species. Okay, they think Africans are producing too much. Okay, we're having too many babies. Okay, and so when you have all of these people who, for the sake of their money, are buying African governments and sort of poking their nose in our policies, you can't help.
Yeah, but feel the mistrust.
Exactly. So that is what is going on. As well as far as my practice goes, my practice is probably about 50-50, 50% Caucasian, 50% African American. And these people are not going anywhere near the vaccinations.
I wondered if we could just get some of the other guys just to jump on as well, and just because I think we've all got stories of how our own patients may not mistrust us. Exactly. Have you got anything to say, especially about treatments as well?
Yeah, no, I think that was a really good insight, Dr. Kwarteng. Thank you. It's really good to share the kind of cross border similarities and differences. I think that, obviously from a personal point of view, my background is from Nigeria, and I've got a lot of family in Nigeria, and I know that a lot of them are really consumed by steaming and the ginger, the garlic, boiling the herbs and all of that. So I think that, as GPs, we're quite accustomed to seeing patients with viral infections, and we do always encourage what we call conservative measures. So things like steam inhalation, paracetamol, and so on and so forth. But I think that the problem here now with COVID is that, as you quite rightly said, Dr. Kwarteng, is that it can be the worst thing ever. And it could be something you wouldn't want to wish on anybody. So, my concern, so I think it's a comment and a question thrown it out there to everybody, is especially in places like Africa over the Christmas period, over the New Year period. That's a really festive communal time for all of us. And I know that, several of my relatives were, cautiously go into functions, but were still cautiously present with their mask sometimes on their chin, but really feeling protected by all the steaming they had done and the ginger they'd eaten that day. And unfortunately, my personal stories in my family, we've lost 3 relatives in 3 months. Two have been actually in sub-Saharan Africa, and it literally just takes you just like that. So I think that I know that certainly I know that we've got a lot of possibly some people listening in from Ghana, and I know that there are issues there right now, because I've got friends whose relatives have fallen ill, and they've done all the steaming, they've done all of those things, and actually some of the challenge is actually finding a bed for admission. So I just wanted to just throw it out there to just see from Dr. Nsaya, I hope I haven't said your name wrong, Dr. Obeng, just what are you advising your patients? Are you seeing this problem? Are you seeing people who are sort of in denial? I know you touched on people think they've got malaria, they think they've got their typhoid, they go through all the other lists before they come to COVID. I know things are changing now, but I think January, certainly what I experienced personally, was quite a bit of a problem for people. So what do you advise your patients, Dr. Obeng?
We might.
Oh, is he gone? Okay. Yeah. Okay. I mean, certainly here, obviously here also we've, a lot. Oh,
I think, Dr. Obeng, I think you are muted. Yes, there you go.
Okay, so thank you. The mic is on now. So, thank you. It's a big challenge here. It's a big challenge. If you look at the life, some people feel, or most people, I would say, feel that COVID is remote from them, it's removed, it's distant, they can't get it. I mean, if you go to the market, if you go to the public transport, people are crammed together in the bus. In the marketplaces, people are crammed together, no masks. And they always ask the question, so what's happening with all these people? You know, it prevents a big challenge for the health authorities. What I do before I had this, I suffered, COVID, was that I make them understand, because I see people, patients, colleagues, relations who have COVID. So I always used to tell them that it may seem so distant from you until someone close to you loses their life, you know? And I think that everywhere in the world, some countries have managed to get it, but this is the time where health professionals have to have this social contract with the people and build trust. This is where, for example, we are talking about vaccination and all the myths about it, all the lies. This is where I believe faith groups come in. You know, we believe in God, we believe in Jesus Christ, but when we were kids, we all took vaccinations before we became doctors. That's what spared us from polio. That's what protected us from yellow fever. So this is just a new disease that's come. It's not somebody trying to take out a race. I know there are lots of commentary and other things which are going on, which makes this difficult. But I think it entirely rests on the government. Look at the UK. Look at Israel is the foremost, right? And if you know people who are very conservative, it's the Jews, the conservative ones. You know, they were not social distancing, and they were dying. They were losing a lot of rabbis. And you know, they're small countries, so their government, you know, they're very smart. They got the vaccines, and now they got them to vaccinate, and now they're using when after a lot of people were vaccinated in Israel, there were a lot of myths, and people were beginning to not go for their shots. What did they do? They said that the parks are open to people who have the shots. The hotels are open to people who have the shots. The people who have the shots now, they can go to a pub, have their drink. Whilst you're having your drink, you can get your shot or second shot. But if you don't have it and you break that rule, come out, you go to jail. So this, I think, is some of the inventive ways governments can use to build trust and save, their populace from dying from this terrible disease. In Africa, our challenge is we have made the disease very remote from the low-income people. It seems like it's only the rich that's dying. It will take a long time for them to know a prominent person got the disease. But I think that we need people who are from local communities who get the disease to also come out and tell them that indeed it's real. This, I believe, is the only way to build trust. If we don't build trust in Africa, whilst the world may be saved from COVID through vaccination and everything, then it will become an African problem like HIV became, It will then be killing people here because people will not believe that I need to take the vaccine to save my life. I need to social distance. I need to mask up. I need to wash my hands. So this is trust is a major rule or the major tool that the health authorities and the populace can use to combat COVID. That this is my take. Yeah.
Can I just quickly jump in there? Yeah, thank you, Dr. Obeng, for that. I think the thing is, we all have family back home, and that's what COVID says. We all also need to talk to our family back home because, for example, my father lives in Nigeria. I haven't been able to see him for a while. And it's just so important that as we spread the message here, we also make sure that the people back home in our respective countries are not missing out on what we're hearing and that we just tell them that, you know, when the vaccine does come to them, that it's safe. So thank you for all the wonderful work you're doing, Dr. Obeng.
Thank you. And I think just
Yeah,
still
thank you.
along the kind of lines of mistrust and why people don't trust the research is that there's a very small percentage of Black people in the research pool. I don't know what John and Daniel thought about that. Either of you can jump in.
Yeah, John, you can go first.
Yeah.
Okay.
Okay, cool.
Okay, can I come in?
Go on, John.
Sorry, who is that? Okay, fine. Yeah, no, so I think...
Okay, John, you can go on. John, you go on.
Okay. So these are deep-seated issues, right? So once again, when it comes to what we're seeing with COVID, it's not something that just started, you know, in 2019. As Dr. Kwatang was alluding to, unfortunately, some of the issues of mistrust are steeped in history and facts, in terms of things not being done properly, in terms of how certain community groups were being treated. But also there's the culture, maybe of the diasporan community, because of the nature of which they've had to immigrate and the nature of how they've had to maybe make an income in some of the lands, foreign land that they've been in, that there's always this kind of skepticism with engaging of the so-called conventional means of medicine. And certainly when it comes to the issue of experimentation, a lot of our people are inherently reserved, particularly when it comes to their health. So the concept of taking part in some sort of trial, something that may or may not be of benefit to you, with the history of mistrust and misgivings, you can't really blame people for not wanting to get involved. So it's a very much a catch-22 in that, you know, getting involved in trials and vaccinations is a matter of information, is a matter of having champions within your communities that you can actually trust, that can give you the right information and get you involved. And it's a matter of history. So if you're not involved and then you question the results at the end, you know, it's a vicious cycle. And I think, you know, one of the things that we have to move towards, certainly in the diaspora and even on the shores of Africa, is being part of the process, being part of the process of trials, of research and data. You know, those things actually are some of the things that will definitely transform healthcare on the shores of Africa. Having, you know, your own raw, or, you know, our own raw data when it comes to all of these things. So these are some of the things that we need to start looking into, maybe as part of a post-COVID strategy, to make sure that history doesn't repeat itself in this way.
Yeah, I think I'll just jump in quickly before anyone else jumps in. So I think my thoughts are just looking at the study data, like the population of people of Black heritage that were involved in the study was just under 10% for quite a few of the studies. That's including the Pfizer study and the Moderna study. And I feel that it was a fair representation in terms of kind of like you're able to measure the effect and see actually that the effect is not any different from people from other ethnic groups. But also, like John alluded to, there was hesitancy in people of Black heritage getting involved in the clinical trials themselves. And I think part of it was also the fact that a lot of these conspiracy theories were already flying around well before the government started making efforts to do something about it. And I think that's probably part of the contribution factor that we didn't want to get involved in the first place, and because all this conspiracy was flying around in our community. So I think that's what I've got to add to that.
Thank you. And I guess just kind of like thinking practically, there's some people who may, after listening to all of this, still won't take the vaccine, or maybe they want to take the vaccine, but actually they're not going to be eligible to take it until maybe the summertime or the end of the year because they haven't got underlying conditions and they're not at the top of the list. So what do you do? What do we do between now and whenever we may take the vaccine? How do we keep safe? Is hands, face, space, is that still valid? What else do we need to be thinking about? That's open to anyone.
I look, the only way to survive is to prevent the transmission. I mean, it's not rocket science. You know, I mean, that is just basically, that is where the opportunity initially was meant. If somebody is typing very aggressively, if they can mute themselves. Um, okay, yeah. So it's like I alluded to earlier. This virus does not transmit through the community if we adhere to the rules and the recommendations. Once again, this is not a bacteria. It does not have the ability to reproduce and multiply in number. So if I am patient number 1, let's just say that by some miraculous reason, something came from space and inoculated me with a virus. If I isolate myself from my neighbor, from my family, the virus either kills me and it just dies with me, because once I'm dead, the virus requires a live person to replicate and get to the next person. So the only way we continue to stay alive is to protect ourselves. Now, I don't see how anybody, after seeing, especially here in the United States, seeing 500,000 people die and still have doubts. Now, if you can look at 500,000, dead bodies and still have doubts, your problem is just more than just, I mean, there is really something fundamentally wrong with such type of thinking. If you can still look at all of these deaths, all of this sort of morbidity, and still doubt that. So I guess my recommendation is that, look, we have to protect the vulnerable populations first. But as we do that, now, the example I give people is, especially from family unit standpoint, if you're a leader of your family, you can be a single mother, you can be, a complete family. If somebody walks through your door and you know they are an intruder, what are you going to do? You're going to do any and everything you can to make sure that you are protecting your family, right? I mean, somebody barges through your front door, you taking the baseball bat and you are going at them. If you're a woman in the kitchen, you picking up the longest knife and you going at them, because you will do whatever it takes to protect your family.
Dr. Kwarteng, can I just ask you a quick question on
Yes.
that point? I think that's really an excellent point. Because you said people will do whatever it takes to protect their family. Now, the issue that I'm seeing with some of my patients and family members and people in my community is they are doing everything they can to protect their family by not taking the vaccine, because they believe it's a chip and it's using nanotechnology, and they believe they will lose their eternal life and access to heaven because it's the mark of the beast. And they really believe this. They really believe this. Obviously, I'm a Christian, and I'm sure several of you on this call are Christians. And it's really difficult to change people's minds. And, as Dr. Kuru was saying earlier, we go to medical school, our families are really happy we've graduated, we're doctors in the family. But when you come and tell them this, it's like a prophet is not respected in their own home. You're trying to tell them the truth, but they're standing on the word of God. This is the biggest issue I am facing within my community. They believe it's a chip. I don't know what they believe we've all become now, chipped, and I'm going to heaven. I definitely am, but it's hard to convince them not to bring out that bat and bat away the vaccine. What do people respond? How do people tackle that?
Well, that is a function of just how our cultures have developed. I was brought up Presbyterian, and as time went on, Presbyterian and Methodist and Catholicism just became too boring for me. I was looking for some spice in my Christian life as a young man in Ghana, and so I became an evangelical. Okay, I believe in prayers and I believe in fasting and all of that. But the more knowledge I acquired and the more I came to understand Christianity, I have come to the conclusion that Christianity, in fact, has done more harm. This is just my personal opinion here, and I'm not trying to be blasphemous, and this is arguable. Okay, when something happens, how do I put it to make sure that it is not so inflammatory? You see, God gave us the ability to think, right? I mean, I think everybody has that. If you really think about it, just hear me out here for a second. When the Europeans came to Africa, and I'm going to give you a little history lesson here. They came under the auspices of Christianity. They gave us a Bible. The next thing we knew, we were in chains going across the Atlantic. We were brought here in the New World, and we built the industry. Human beings were sold as forfeits of a property. But these people were under the guise of Christianity, and they held the Bible as justifying their actions. God created man in his own image. How does one person take another person in servitude and treat them so inhumanely and then use God as a justification? And so for my Christian brothers and sisters who think like I have to go to a location to pray to God, you are limiting the presence of God. And you are limiting the omnipotence, or the greatness of God. Before you were born, God knew who you were. So why do you feel like you need to go to a particular location? Do you think that that is the only place? Because for me, it becomes a contradiction, okay, in my head, that I believe in this great God who is capable of doing all things. He created and earth, but yet I need to go to a particular place. And the reason why this is important is because, I feel like Christianity, the way it has been perpetrated in our local communities back home, has really corrupted the thinking. And I'll give you an example.
So do you think this is just a case of to listen to the word of God and not to the word of man?
Yeah, I was going to say, with all due respect, actually, I was going to chip in on that. I mean, and I think with all the, without turning this debate into, or this discussion into something that it wasn't intended to be, I think you're 100% right on the misgivings of faith, and certainly Christian faith, and some of the damage that it's been caused. And I think what's always important as learned people, people of faith, is always to try to separate the message from the messenger, and not to conflict the two. I think human nature, by definition, is one that is corruptible, and whether it's greed, fear, or whatever it is, whenever human beings are involved in something, it's always subject to abuse. So we have to try and separate the two. And I think coming back to the issue of COVID and maybe vaccination, I think that faith leaders have a major role to play, as Dr. Yao alluded to earlier, certainly in rallying the communities together and not, perpetrating or benefiting from fear. We had a faith leader in London that was selling some sort of anointed oil as a cure for COVID. I mean, look, as far as I'm concerned, faith leaders have to be able to call that out and say that's just outright wrong. So I think that's kind of where things need to move to with this discussion and with future discussion. And, everyone, we're always going to have opinions, but I think on this particular issue, we should unite our message.
Oh, no, I mean, don't get me wrong, and I'll just jump in here. So the point I'm making is the role of the faith leaders. So Chichi mentioned, because Chichi had a real concern of our family members. I was brought up in a Christian home, and my sister is married to a pastor. I have pretty much, for those of us overseas, I would say about 30% are in ministry. You know, I still worship. But the point I'm making is that for the listeners, I want them to sort of think independently and not sort of miss or undermine or belittle the importance of God. Because when, especially in Ghana, when the president did the most recent COVID update and they were reinstituting the restrictions, I realized that funerals were restricted and this is restricted. Yet, religion was given a free pass. But the point I'm making is that if we can restrict certain activities, why are we not restricting religious gatherings? But as a believer, I'm trying to impress upon people that God is all-knowing. Okay, so you don't have to physically go and congregate because we know how this thing spreads, right? So that is the point I'm making. I'm not trying to be blasphemous here, and I'm not trying to move away from the topic, but I want listeners to understand that yes, go ahead and believe in what you believe in. Okay.
Yeah, I have online church. I've got online church tomorrow and looking forward to it.
Okay, so that is the point I'm making.
Yeah, so I think COVID has impacted on so many people. I guess when we talk about church and faith, we talk about the importance of you know, how mental health has been impacted during this time, and actually we forget how useful it is to gather together. I just wondered if anyone wanted to touch on kind of isolation and mental health impact during COVID, and how do we manage it? How are we going to get through COVID if we can't meet up with our family, with our friends, with our church, even go to work, some of us? How are we going to get through COVID?
Let me jump in on that one, Kuru, because I went to a really fantastic online webinar today that the Association of Black Psychiatrists in the UK did today. It was phenomenal. So if you do get a chance, once they release it on the YouTube, please do listen, because I think the concern from the consultants that were speaking was that we are on a mental health time bomb, literally on it. It's already exploded, but the depth and the breadth to which it will explode is huge. Obviously, here in the UK, we're on our third lockdown, and the lockdowns have been quite strict in comparison to other countries. You know, my brother lives in Dallas in America, and they have not experienced this because they're still, you know, they've got some elements of freedom, which obviously now they've got the snow, so that's a bit different. But throughout the last year, life has almost sounded normal. But for us here, life hasn't been normal. You know, I haven't seen people in my church physically for 1 year. Some members of my family I haven't seen for over a year. So, you know, even over the summer when our lockdown was partially a little bit looser, you know, not everybody had the liberty to be able to mix with people. So that's really affected everyone. It's really affected everyone. And I think that, you know, everybody has a story to tell. We're all at home. You know, some of us are having to work from home. Some of us are having to school their children from home, you know, without consent, really. People are having to just be stuck. So what we've seen is things like domestic violence has increased. We've seen anxiety and depression. I mean, that's a bulk of my work right now. It's a huge amount of my work as a GP. But literally, you know, my concern is as the nation returns to some element of normality. So as our government removes some of the financial support they're giving to people, there are many businesses that have already just crumbled, but there are people that literally, I'm so worried about the mental health aspect that would deepen and worsen. And actually what we've seen is that a lot of women have been affected massively. We've seen that suicides have gone up. And yet, obviously, in communities like the Black and ethnic minority communities, mental health is not something people talk about. You know, I don't know how people handle it in Ghana, but even here in the UK, some of my patients won't just come up to me and say, "Doctor, I'm depressed, I'm anxious, I'm suicidal." They might just say, "Doctor, I've got a bill to pay," or something else, or I've got a rash. So it's important that we keep the dialogue, and yes, COVID is here. Yes, we've got a vaccine, but we have to, as you rightly said, Dr. Kuru, we have to address the mental health impact, because I'm worried of the excess deaths that's going to happen. So that's my bit to say about that. But as a doctor, I'm so concerned.
I mean, I think thank you for that, Chichi. We've covered kind of a wide range of topics here, from really understanding that COVID affects everyone. Black people, Africans are not immune, that we need to kind of, when we have symptoms, we need to make sure that we seek help where we can. Although we know that's a challenge in places in some places in Africa. So I don't know who's taking some rapid notes. And also that we need to trust that it's real and respect the rules and keep in place, as difficult as it is, but also recognise that faith was common sense. Faith and medicine can definitely coexist. It's good that's given us the wisdom to get as far as we are, and to really just look after our mental health where possible. So I think one of the things that really comes out to me, that I think Dr. Kwarteng said actually, is that you said about where you work. You work where the action is, and I think it's really a blessing that all of us here, we actually work on the coalface. We actually all see patients during this period, and I don't know if we say we don't have the privilege, or we haven't stepped back from where the action is, and we won't stop doing that. This is about improving people's health, and people's health means our health and our family's health. So I don't know. I think, unless anyone else has got anything, any new topics to raise, I think we can come to a close. But I wonder if we could each kind of go around, and if you have any final comments, or anything, words of encouragement, or anything you wanted to share with anyone, please feel free to share that.
Dr. Kuru, someone is asking, and possibly, if someone else wants to answer this, they've asked, so what are some of the practical steps people suffering mental health can take?
Dr. Daniel or Dr. Oben, could you answer that?
Yeah. Well, in the UK, first of all, let me try and say everywhere in terms of practical steps you can take. I think important thing is to stay connected. So even though we might not be seeing people face to face as we are, find a way to connect with people and stay connected on the WhatsApp platform, the Zoom platform with friends and family. Talking helps. Talking makes things better. Also, try to engage in regular exercise. So these are things that we advise our patients all the time. Eat healthy, and also just mind and keep and look after your mind, look after yourself. Like if you find like the news is making you depressed or stressed, turn it off for a little bit. And there's a bit of self-care that needs to go into it as well. And the other thing to mention as well is that you could always basically, your doctors are still there, your GPs are still there. Give them a call. You can make phone appointments and video appointments to speak to them about whatever you're going through. And quite a lot of the services are still available, at least here in the UK. You can be referred by your GP or given the details of how you can contact mental health services. In the UK, you could just go on the NHS website, search for it, or usually depending where you live, if you just type in talking therapies, that will bring you the nearest center that's available that you can refer yourself to either online or via phone. Everywhere else, I guess, probably speak to your doctors. I'm sure they will advise you on where to go.
Yeah, can I just quickly chip in on that? Because, for me, my life has changed quite significantly, having lost people in my family who were quite matriarch figures in my family. That just changes your whole view, and you start to think about why you here, what's your purpose, what's the point of family. You're still grieving and supporting people. And I would just say to people who are going through something like this, just take each day at a time. Tell people what you're going through. Let people talk to you, pray with you, but just don't try to plan too far ahead. Just take each day as it comes. Enjoy the day for what it is. Go out, enjoy things. And as Dr. Daniel said, take practical measures as well for yourself. Exercise, do something different. And some people might also be worrying about financial realities. You know, yes, the government here has given support to a number of people, rightly so, but there's a huge amount of people that have not received any support. And sometimes I get patients calling me up and saying, I don't know what to do. They literally have nothing. You know, people often think in the UK that people are flushed with money, it's there, but there are people right now who literally have nothing. And once again, as Dr. Daniel said, it's about seeking support from people like the National Debt Helpline, different charities that can support people financially. You've got the food bank. You know, there's absolutely no shame in the matter, because nobody asked to bring this upon them. So there are lots of different things that people can do to help to support themselves and to go through this time of uncertainty. And when it all comes down to it, you know, you've got to recognize that there's no problem bigger than your life. You've got life, you know, you've got air in your breath, you know, you've got a chance. So just don't give up. As long as you've got air in your breath, you have a chance. There is a chance, and there has to be a way. So that's just something I want to encourage people who are listening today.
Thank you. I think as we said, we were coming to a close, a few questions came through. So we've got one more, and I think maybe reiterating a point that we said earlier. And the question is, the hospitals only want to be contacted when you have severe symptoms. What should one do while at home with mild symptoms before it gets worse? Can anyone answer that? Dr. Obeng or Dr. John? Yeah.
Yeah, well,
Dr. Obeng, Dr. Obeng, do you want to take this? So I'm guessing the practicalities will be slightly different in terms of being in Ghana versus being in the UK. So I mean, from the UK perspective,
Thank you.
I think where we are now, knowledge is power, and I think the most important thing that I would stress is that a lot of COVID patients were either asymptomatic or have very mild symptoms. You have to remember that. I know Dr. Collins and you both had quite severe versions. I mean, I had it and I didn't even know. I think I had a headache for a couple of days. But what that emphasizes is that there is a place for care at home, and certainly simple measures in terms of taking painkillers to help with headaches, being well hydrated, and you know, just following the routine. I mean, there are lots of advice on NHS websites about this, so we know all of those things. I think the most critical thing, however, that I would say is not to suffer in silence and know when to call for help. So key strategies, I would say, if you feel that you're developing symptoms, reach out to alert a family member, definitely, of what you're going through, so that someone can always check up on you, or someone in your community, so that if things are deteriorating, and you can't escalate yourself through your general practitioner, that there's someone there that can escalate on your behalf. That's very important, because unfortunately I've heard of scenarios in which people have tried to cope at home and they couldn't, and then there's been no one to escalate. So that's something that I want people to take away from this. There's a big place for care at home. Just simple conservative measures of keeping well hydrated and taking simple analgesia without complicating things and taking all the other kind of recommendations that some people talk about. But knowing when to escalate, that is very important.
Thank you. Dr. Obeng, I don't know if you're back, if you wanted to contribute, otherwise we can wrap up shortly and just have a final conversation. I don't think he's there. All right, guys. Thank you very much for joining us on this panel this evening. I think what I've noticed about COVID is that you can talk for days about it and still not cover all the topics. But I hope that everyone has a little bit of information they can take away to keep themselves safe. And that is the most important thing. Keep yourself safe, please. If we have any more closing comments, Dr. Kwarteng. Sorry, you're muted.
Yeah, thanks for the opportunity to share the experience and maybe also do a little bit of teaching on this topic. I think the closing comments I will have is that I echo what everybody else has said. You know, the hospital system is overburdened, and people appropriately so for lack of knowledge, they will suffer. So I think some of it is education. Um, so just managing, knowing when to sort of pull the lever to ask for help is extremely important. But there are many things you can do, like Dr. Afloyan said, that make sure that you have family members who are checking on you. When I got sick as a big man, my mother was checking on me like, 20 times a day. It became aggravating sometimes. Have you eaten? I mean, have you used the restroom? I'm like, Mom, come on, man. So having loved ones check on you, it's extremely important. But education is key. Now, to buttress what Chichi said, this is probably the most devastating pandemic of our lifetime. Businesses have shut down, people's livelihoods. This is where leadership comes in at the local level, at the regional level, and certainly at the governmental level, because the greatest resource of any nation is the human resource. All right. If we allow our social structure to break down, okay, because we are looking at our balance sheet as a nation, it doesn't mean anything if at the end of the pandemic, half of your productive population is gone and they are unable to contribute to anything economically. So for me, it does not make any sense. And I don't mean to make it political when people cannot even get $1,400. Okay, to just meet their basic responsibilities. And I think that is criminal. You pay taxes all your life, and then when the time comes for big government to come in and make sure that our social structure continues to survive this pandemic, we play politics with people's lives. And that is the one thing that bothers me about all of this. But like Chichi said, when you are up and breathing, then there is always, whenever there is a will, okay, there is always a way. Okay, so keep your heads up, and we are going to get through this. And so keep protecting yourselves and one another. Okay, and we will get through this. And when we get through this, we're going to be much stronger than where we started. So thanks for the opportunity, and you guys stay safe out there.
Thank you. Okay, guys, I think this is the final call for final comments. Anything to say?
Oh, did you say my name? Sorry.
Yes.
No, I just wanted to echo that it's been great just to really have this forum of, it's an international forum, isn't it? We've got UK doctors, we've got American, we've got Ghanaian. It's just been amazing. So thank you to the organizers for this opportunity to really just have, it feels like we've had a round table discussion over a dinner table. And we just want to be open. We just want to be free. It's not scripted. We're just talking, and hopefully those who are listening at home, like a fly on the wall, have just heard us just bounce things off each other. I just really want everyone to stay safe and make the right decisions for them. But please, listen to the right sources. Don't believe everything on WhatsApp. The vaccine is a good thing. And please protect yourself. And I hope that as Western countries, we will be able to give vaccines to countries who may not have as much resource. And certainly I know that the trade minister, the World Trade Organization have spoken out today about it, certainly to our UK government as well. So hope is on the horizons. Thank you.
Dr. Obeng, have we got you back in the house? I don't think
yes, it's been a great. All of you are out there. We are here, and I believe this is a big test for the West. There's a disaster this time. It's not only in the West. It's hitting the West more than the African, and we're all struggling to see how the African will survive this time. And Dr. Pani talked about it, the human resource. We are praying and we are working and hoping that by the time COVID is really controlled all over the world, Africa will not be left behind.
Yeah.
Africa, we can only continue with the interventions until finally we get the vaccinations. I mean, I don't know when it will come. All the pledges can be made, but as Dr. Patton said, it depends on the leadership of the African leaders. I mean, if they want to help their people, they can. If they want to wait for people to donate it to them, it's up to them. So it's a big, crucial time for Africa, how we're going to survive this pandemic. You know, we don't have the resources to put the statistics out, but I feel the statistics might be worse than it is because we don't test like they test outside, and we don't collect data like it's done in the world. So we can only hold on to it more than maybe anything else and just do what is practicable to, I'll say, prevent yourself from getting or catching the infection. That's your surest bet, because you can't help the cause of the disease. Yeah.
Brilliant, thank you. So the line was cracking up a little bit, but I think the most poignant thing you said was Africa should not be left behind, and prevent. Our African leaders fight for us. Daniel and John, do you have any final points? And then we go back to Minister Douglas.
Yeah, I was going to say that I think it's a good opportunity to actually mention to people that might be listening from other parts of the world, especially in Africa, that even like from what everyone's been saying, from what Dr. Oben's been saying, I think yes, there are valid concerns, as Dr. Parteng alluded to earlier, and yes, some of your concerns are valid, but some of the concerns as well, they're valid for you because that's how you see it. But in terms of, I think we presenting ourselves as people that are from where you come from, whether from we're from Africa, most of us are from, but also we're trained partly in Africa or fully in the Western world, whether in the UK or the United States. And we're saying that we've looked at the data. The science is sound. We're not worried about the science at all. From an ethical point of view, we have no worries at all. And I feel that probably if you still have any questions, I would say probably do reach out to GTP, and they can get in contact with any of us to help to answer any of your questions. I would say that's the best thing I would say. If you have any questions about this, ask your doctors or get in contact with an organization that is trustworthy. Because we're talking about Africa, it will still depend on a willingness for people to get the vaccine. So it doesn't matter how much vaccines we donate to countries in Africa or how much vaccines they buy. If people are not going to take it, then it's going to be a waste of time and a waste of money. And also, unfortunately, it's going to lead to more loss of lives. That when people are not actually counting as COVID deaths, but people I know from my experience in my circle are dying from COVID, even in places like Nigeria. So that's what I would say.
Thank you. And John, and you're closing us out.
Myself?
Yes. If you've got any final comments.
Yeah, look, there's nothing really to add to what my esteemed colleagues have said. I think it's just the only encouragement is that this is a unique time in our history as human beings, and we should learn from this experience and use this opportunity to really form part of a bigger picture, bigger discussions about our health and well-being, whether that be here in the Western world and Africa, just so we as a human population can really develop a healthcare system that works for everyone.
Thank you very much. And I think that brings us to a close. Thank you everyone for joining us. Not quite sure if we're going back to SC, are we? If we're not, I think that's it for today. If you have any questions, I'm sure you can post them in the YouTube chat. Speak to your faith leaders, speak to your healthcare professionals, and I think above all, trust us, please. We studied a long time, but we are very much mums, dads, brothers, sisters, aunties, uncles. We are still just as you are, and we are going through this the same way you are. So thank you very much.
Pastor, you show up finally. Where were you hiding? We needed And
That's a good point, actually. What happened? It just popped up all of a sudden.
exactly.
We're still live, guys.
Program.
Yeah, you were probably behind
You are.
yeah, enjoying some Omutu and some better soup there.
No, I was enjoying everything that you were saying.
All right, guys.
I was enjoying
Okay, well, it was a pleasure meeting all of you here. And let's stay in touch. I just sent a message to Dre to get all of us are connected, and I know we are still live, so don't say anything incriminating. Yeah, so it really was an honor to get the opportunity to share the stage with all of you. I value the inputs, and I feel like I've also learned a lot. So let's stay in touch, and I concur with any and everything that was said. And you know, one of the things we can actually do is to sort of collaborate. You know, there shouldn't be any sort of national barriers or anything like that, so that we can do all that we can and to sort of help our folks. So I'm always open and ready to roll up my sleeves to get down to business. So, you know, if I need to take, see, the good thing when you are in private practice is that no one signs a paycheck. All right, so you can shut up your shop and get on the plane and go anywhere, whenever, you know, and get things done. So I'm always available to help whatever will make our continent a much better place. I'm always good to go. So guys, enjoy the rest of your weekend, and I think I'm gonna bounce. All right.
Thank you so much.
All right, guys.
All right, bye.
Bye, everyone.
Thank you very much. Thank you very much, panelists. I'm so grateful to you, for all of you to show up from all the way from the US, all the way from Africa, Ghana, and the rest of the doctors here who took part. We are grateful to you, and we know that anytime we call upon you to come and help us in some serious business like this, you show up and help us. We are grateful to you, and thank you very much. I want to thank you, Dre, especially. You've been so good to us, GTP. We are so grateful to you, Dre. And we ask that the Lord Himself will bless you and keep you and protect you from this pandemic, that you never have any problem with your health, whether now or in the future, in Jesus' name. I can only pray in Jesus' name, because that's the person I believe in. That's the God I believe. And I pray that everyone that took part, the participants, the panelists, from Dr. Chichi, who is the MC or the coordinator, to Dr. Kuru, who was the coordinator, sorry, beg your pardon, Dr. Kwatin, Dr. John, Dr. Osigbe, and Dr. Yao from Ghana, all the way from Ghana. Thank you very much, and may the Lord bless you and bless your businesses. We pray that every other thing that you intend to do concerning your businesses, private businesses, and other business you do, that God will bless you and keep you safe from all evil. We also want to thank all our participants, all our audience who took part, and every sponsor that also helped us. Everyone that contributed to making this program a success. Following from this, on the 27th of March, we'll have another program called Excelling in the Crisis. Excelling in the Crisis. And we want everybody to tune in on that day between 7 and 9 p.m. again, UK time, to watch. That will be on business, in business. And as I say, you know, Graduate Inspirational is not just about for graduates. It's for everyone who wants to achieve something great or become successful in the area they choose. So please look out for it as we will post it, and bye. Thank you very much. Thank you.